Assalamu alaikum, this is Shamama and today my video is again the continuation of my topic dysmenorrhea. So this is the last video on the series of videos on dysmenorrhea. In this video we'll basically discuss overall how we will manage a patient of dysmenorrhea. So basically by this video you can easily first objective you'll get is that you'll know how you have to attempt a scenario if it comes to you of dysmenorrhea as an SEQ, plus a complete you'll know that how to take the history of the patient, how you'll go for examination, what will be the investigations for this disease, and some very important differential diagnosis points. So this will be our whole discussion on dysmenorrhea in this video. So let's just start a video. First of all, we'll take history of the patient. So in history, what we'll do is, of course, patient is having dysmenorrhea, pain. So we'll take history of pain of the patient. Now you remember the mnemonic OD para. So for pain, we go for site. What is the site of the pain? She'll say that my pain is mostly on lower abdominal. We'll click that okay, this can be pain of dysmenorrhea. Second, we'll ask that what is your onset of pain, when the pain starts and all the time. So on this point, on the basis of when the pain is occurring, when it is becoming worse, or when severe symptoms are developing, you can easily make some differential diagnosis in your mind depending on what she gives you the history. Like an example is that if she say that I have feel pain when there is passage of clot from my body, so what we'll do for treatment in that case, that we will give those medications to that patient which will decrease the bleeding in her, so as a result her pain will be relieved. Moving on, we'll ask her that what is your duration of pain, how your pain is progressed. Then if she say that my pain is mostly progressing towards my legs, down to the legs, so that is characteristic of dysmenorrhea, it radiates down to the legs. Then her aggravating factors, her relieving factors for pain. For relieving factors, we ask her that whether by using some heat on the body you feel good, or you take some medications. If yes, then which medications you take. So we ask her about associated symptoms, in which she'll mostly say that I feel nausea or vomiting or diarrhea or flushing. So these are the common features. Then talking about the severity, may you will ask some questions from her by which you will assess the severity of the disease. You'll ask her that okay, when you are having menstruation, whether you take whether your pain is so severe that you have to take medications for its relief. So then you'll assess that okay, if yes you're taking medications, then which medications you take. Then you will assess that okay, which degree of analgesia she is taking. By that you can assess the severity of her pain. And moving on, next question will ask her that okay, when you have menstruation, so in that case, is there any situation that you can't do work, you have to take off from your daily routine? So that will tell us her condition. This is all about the history of her pain. Second, we ask her about degree of menses, that like how much bleeding you have when you menstruate, when you have this much severe pain, this dysmenorrhea. So why we're asking it, and this is particularly by the observation of the female. You have no hard and fast rule that whether you ask her some particular thing. We'll just ask her some particular questions, like for assessing the degree of menses. We'll ask her that okay, whether your pad which or the sanitary pad you use become filled up to its margin, or whether it causes a spillage on your clothes become stained because of menses. So these such questions you'll ask from her for assessing the degree of menses. Plus you'll ask her that okay, when you're having menses, then if you compare it with your previous periods, you are having more bleeding or less bleeding. So that is an important point. Now what is the differential point that you have to notice here is that okay, when the female says that she is having excessive bleeding, mean menorrhagia, increased bleeding, then some differential will come in your mind. If you remember the etiology, I told you in acquired that there was a classification of causes which are within the wall of the uterus. Now whenever the cause is within the wall, then of course you can remember by the point that if it's a cause of within the wall of the uterus, that wall will damage, of course, then it will lead to bleeding, of course, and increased bleeding because of increased damage. So this technique in your mind will tell you that okay, if the patient is having menorrhagia, then my defenses can be either endometrial fibrosis or adenomyosis. Okay, then there are some terms which you should know, that these are also told by the patient, which tells you when you're taking history that I have abnormal uterine bleeding, or I have intermenstrual bleeding, or postcoital bleeding. These are the 3 important points. This is all about history. Now we'll proceed about the examination. Whenever we go for examination, we start with the general physical examination. So in the GPE, what we'll see, that first of all we'll see the general condition of the patient. Now you know, when a patient is having severe pain, then she will be drowsy, she will be anxious, and she will be confused because of that pain. We will take vitals of her BP, pulse. Mostly pulse is feeble, or BP will be low because of pain. Then we'll see pallor. Now while we'll seeing pallor, that if we note pallor in the patient, we can easily have a shortlist diagnosis in the mind that this pallor is because of excessive bleeding, means menorrhagia is being faced by the patient. So second is abdominal pelvic examination. So when we do so, mostly you can have a sign of mass. We'll feel a mass here. If we do so, then we'll take the size, shape, surface, tenderness. These all properties will be noted. Moving on to pelvic examination. Now very important, we don't do this examination if the female or your patient is unmarried. We don't go for that. But if she's married, then we go for pelvic examination. So first of all, we'll inspect the vulva. But we'll see, we can find imperforate hymen. That will be an important finding. Second, we go for speculum examination. Now in the speculum, we'll go for vaginal discharge and the uterus, whether it is fixed or not, movable or not, the endometriotic nodules. Those nodules are basically blue spots at the uterosacral ligament, the ligament that attaches the posterior surface of uterus to the sacrum. That is a ligament. So blue spots are seen. It will be diagnostic of endometriotic nodules. Plus we can find any polyp or any intrauterine contraceptive device. Moving on to the third modality, that is the bimanual examination. Now what is bimanual examination? Bimanual means we are using our 2 hands. Okay, now I'll just little explain you here because it's an important point. What is bimanual examination? The doctor uses her 2 hands. Left hand is placed on the pubic symphysis of the female, and the right hand, index and the middle finger, is first lubricated, then it is entered sideways into the vagina with your palm facing on your side, and in the vaginal canal it is twisted in so that your palm faces upward. Then we exactly